when do I start?
They're joining right now.
Sure, sir.
Maybe we start. I can talk for 5 minutes before they join, and then we start the case. So everybody is joined by the time.
We are going live in 3, 2, 1. We are live now.
Shall I start?
Yes.
No, let the participant join, sir. Just wait. Sir, you start now.
Sure. Good evening, good afternoon, and good morning, ladies and gentlemen. Welcome to Secrets of Neurology, Knowledge Feast for all neurologists. And today is episode 47. Just one episode, and we do the longest running web series in the field of neurology. We are about to complete 4th year. And today, a warm welcome, apart from our program directors, to the wonderful team of Medanta, who are going to present a very interesting case on what more to look at in dementia. All this has been possible, ladies and gentlemen, because of untiring support, academic intuition, and also nurturing effort of our 2 program directors, who has been instrumental in leading it right from the beginning, 4 years before. Ladies and gentlemen, it's my honor and privilege to introduce none other than Dr. Sudhir Shah sir, who needs no introduction in the field of neurology. Sir is professor and head at NHL MMC and SBI MSR. He is director of neuroscience at prestigious Sterling Hospital. Many awards and accolades to sir's credit. We all know he is extremely modest, but he has also been conferred the most prestigious awards, such as Padam Shri for his work in the field of neurology, service to community and patients at large. Dr. Sudhir Shah sir is also recipient of Dr. B.C. Roy Award. He is recipient of UNO Award, and he has featured in the field of neurology and for his own research work into various channels as well. Neurodegenerative disease, epilepsy, and stroke is his line of interest. Our second director, Professor Dr. Lakshmi Narasimhan sir, we know him very well. He went on to build an institution, and then he went on to join as director and professor department of neurology at prestigious Sri Ramchandra Institute of Higher Education and Research. Excellent contribution in the field of neurology and academics, not just at domestic level, but also at an international level. Sir is recipient of Paltussi Advisor from an A.B. Bakers Award as Global Best Teacher. Sir is also recipient of Global Elsevier Atlas Award, and the list goes on. He has been serving in the field of academics, and he has nurtured many talents who are now the leading neurologist of the country as well. I think we are extremely fortunate to have such 2 wonderful program directors who are running the longest running web series in the field of neurology. May I welcome the wonderful team at Medanta and also our program director, and may I request our program directors to take it forward from here.
Thank you very much, Dr. Manoj Kumar, for this lucid and quite detailed introduction and very kind words. Actually, we are also very excited that we are almost reaching completion of 4th year. With the next episode, we'll complete 48th episode, and that will be a landmark, a real golden point in the whole web series. And I must confess that I have not seen such kind of long-lasting series with a lot of enthusiasm on the part of delegates, the speakers, and that is the reason why we as organizers are always prompted to continue this and bring it better and better every time. And therefore, I thank all the speakers and all institutions who have participated so far. Also want to thank all the delegates for pouring such a great interest, asking questions and repeatedly giving feedbacks. Thank you really from the bottom of heart. Thanks to Dr. Lakshmi, my co-post director, for his unwavering efforts. And of course, thanks to Mr. Arun Chadha, Dr. Manoj Kumar, Dr. Shweta, and the whole team of Celestial, that is the global cell division of Intas Pharmaceuticals, for their networking and efforts to, make this series very successful and very sought after series. I know that there are students, there are professors, senior people, and my teachers also time to time attending this web series. And there are people not only inside India, but outside India from various countries, from USA, UK, Canada to Spain, like Barcelona, from European countries, and nearby countries like Sri Lanka, Singapore, and our neighboring countries also. So thank you all for your continuous encouragement and support. Now, today we have a team from Vedanta, led by Dr. The presenter is Dr. Piyush Varshney, who is the DM student, is third year neurology resident in the Medicity, Gurgaon. He is MBBS MD and now doing residency. He's a former senior resident department of medicine, NCSC Medical College, Jabalpur, NSCB, and former assistant professor, Department of Medicine at Kidi Medical College and Hospital at Mysore. Next slide, please. So he will present the case, while Dr. Kshitij Bansal, who is a consultant in neurology in the Medanta Medicity Gurgaon, who is DM and is DM neurology from GMC Kota. He will take this case forward to localization and dissection of the case, and etiology-wise, etc. He has published a paper, a retrospective study of demographic profile and risk factors associated with basilar artery occlusion in Indian perspective. And he has a lot of achievements, like third prize for poster presentation at API Delhi State Chapter 2019, best paper award in Epicon 2020, first prize in e-poster presentation at NICE Live 2023. So then comes the boss, Dr. Vinay Goyal, a very senior man, most sought after neurologist as far as the movement is also concerned, former professor at AIIMS. He has joined AIIMS in 2001 and was the next professor till 2020. He was past president of MDSI 2020-21, past editor-in-chief of AIAN since 2018 to 21, and then continued from 21 to 23. He is a fellow of Indian Academy of Neurology, founder member of MDSI, PRAN, PRI, ADS, AOSM, MDS, executive member of so many prestigious institutes, DN executive member, Delhi, the association, NSI executive member, and so on. The list goes on and on. He had the winner of Dr. Kapil Sur oration, UK Neurocon. He had a plaque of appreciation, King's Advanced Parkinson and Toxin Academy, Dubai, and Boehringer Ingelheim Scholarship, and Pride of RNT Medical College while he was doing his medicine, while at 60th year of hello, yes. So he has to got lot of awards, including Positivity Award of PBRFI 2019, Vishishta Chikitsa Ratna Award by DME No Wonder in 2012, IMAAS Distinguished Service Award 2007, Shiom Bansal Shiv Shakti Group Award 2000, and if I go on speaking, there'll be many more, lot of gold medals also. But apart from that, we know that he's a very, very acute neurologist with a high clinical sense. He has published lots of papers. He has a wonderful career as a movement specialist. He is instrumental in encouraging and inspiring a lot of new generation neurologists. He has several students across India, and he is one of the finest movement specialists, not only in India, but is well known globally also. So he's a personal friend, and I can add a lot of things on my personal level also. But he in special interest is movement disorder, Parkinson's disease, DBS in movement disorder, botulinum toxin, and intrathecal baclofen, myasthenia gravis, and multiple sclerosis. We had the honor of having him at Ahmedabad on several occasions for my Neuro update, which we have finished 20th consecutive year last time, and we'll be holding 21st Neuro update this year also. He has to his credit more than 340 publication, a massive number. A lot of chapters in books and updates and peer-reviewed articles in journals, 200 international and national, 140, so on. So we have a very, very giant, you can say, doyen of neurology here today to give expert comments at the end of the case. So once again, I'm thankful to all of you for this wonderful feast of neurology. You are the reason why we are continuing. All my delegates, we are very thankful on behalf of Dr. Lakshmi and my team, and of course, on behalf of INTAS, Celestial Division. We are all very fortunate to have you every time, and we welcome you aboard. Thank you. And with that, I hand over the mic to Dr. Vinay Goyal. Dr. Vinay, please.
Thank you, sir, for a kind introduction. It's always an honor to meet you in person as well as to know you. I've known you almost for last now 20 years, and every time I meet, it is very inspiring, and it's always good to learn from you. Today, we have a case which will be presented by Dr. Piyush Varshney, who is our third year DNP resident, which will be dissected by my colleague, Dr. Kshitij Bansal. So let's start, over to Dr. Piyush Sani.
Okay, sir. Thank you, sir.
Please let him share his slide. आपके slide share कर दें? हाँ.
Slides are visible, sir.
No, अभी share नहीं हुआ.
Okay.
पहले किया था आपने. हाँ. Correct. Full screen कर लीजिए.
Yes. Okay, sir. Shall I start, sir?
Yes.
Please go ahead.
Okay, sir. Good evening, everyone. Myself, Dr. Piyush. I am Dr. DLB resident at Vedanta. I am going to present a case on dementia. My title is What More to Look at in Dementia. Patient history. Patient is a 39-year-old male patient. He is right-handed, studied MBBS, and he is born to non-consanguineous marriage. And informant is his father and wife, who are reliable. Patient presented with the chief complaint of change in the behavior for last 10 years and forgetfulness for last 10 years. Patient history, patient birth history was normal with normal developmental milestone with average scholastic performance. He had an active and independent life, managing his business alone, loving and caring his family and friends. Used to read newspaper, watch cricket and political news in a television, and socially active man. History of presenting illness, change in behavior for last 10 years in the form of easy irritability for last 10 years. He started to get agitated with small mistake of or even without mistake of his factory worker. With intermittently, he showed the verbal aggressiveness, but he was non-abusive. He started remaining quiet for last 7 to 8 years, not taking part in family conversations, with loss of courtesy towards guests for food or tea, stop and even stop greeting the guests. With reduced conversation and speaking, since last 1 year, he stopped reading newspaper and watching TV. Otherwise, there was no history of any worthlessness, sadness, or crying episode, etc. He used to play with his daughter, helped her in school homework. Whenever she fell ill, he didn't go to the factory that day and stay with her and care her. But since last 3 years, he didn't bother for her illness and stopped care, even stopped playing with her now. For the last 4 years, he used to face problem in parking the car frequently. He used to bump the car in the parking slot. Since 1 year, he completely stopped driving car. For last 3 years, he appeared in front of everyone without any clothes, which is very frequent for last 1 year. And after being repeatedly asked by his family member, he used to wear clothes. Otherwise, there was no history of any hypersexuality. He has a habit of planning things, what has to be done tomorrow, and used to make list of goods to be shopped and used to plan trips and movies. But for the last 4 to 5 years, he make frequent mistake in all these works, and since 2 to 3 years, he stopped doing all this. Forgetfulness since 10 years in the form of he used to misplace his belongings like mobile, wristwatch, pocket object kept by himself, and also forget to transfer messages and important business related phone calls, and become angry with himself with the repeated mistakes. For the last 3 years, he has trouble performing financial matters, frequently used to give more money unnecessarily to his client and factory worker, due to which his family suffered huge financial loss. Now he used to pay money under his father's supervision. At present, he is still independent for his routine activities like bathing, dressing, eating, and can use mobile and television remote on his own. And he used to go to his factory with his father, but has no productivity in this. Otherwise, there was no history of any change in the dietary habit, no repetitive stereotype behavior, trouble in an understanding or reading or naming, difficulty in dressing, manipulating objects using hands, getting lost in familiar or unfamiliar surroundings. No history of bumping into the object, difficulty in recognizing familiar person, inappropriate laughter or crying, hallucination, delusion, and acting out of dream, unprovoked fall, and excessive loud snoring and daytime sleepiness. No history of numbness, abnormal sensation or reduced sensation of hot and cold water, difficulty in buttoning, unbuttoning, opening jar doorknobs and raise arm above the head, difficulty in no history of difficulty in climbing a stair, going down a stair, getting up from squatting or sitting position, no history of twitching in the limbs or thinning of any limbs, no history of unsteadiness of gait or reaching the target object in a single attempt, no history of any bladder, bowel complaint, dizziness on getting up from sitting or the lying down position, no history of erectile dysfunction or slowness, stiffness or abnormal movement, reduced smell or taste, no history of visual blurring, difficulty in color perception, no history of double vision, drooping of upper eyelid, reduced facial sensation, or difficulty in chewing, rotating food bolus inside the mouth, salivating, drooling of saliva from angle of mouth, nasal regurgitation, or change in speech or reduced tongue movement. No history of any fever, nausea, vomiting, headache, weight loss, reduced weight, no history of any jaundice, abdominal pain, chronic diarrhea, skin pigmentation, and no history of stroke, encephalitis, or the trauma. Past history was insignificant. Personal history, patient was married and he has one daughter of 13-year old, and he is businessman by occupation and upper social and belongs to upper middle class with no history of any addiction or no high risk behavior. Family history is one brother and one sister, and he is the elder one. And there is a strong family history of mental illness in his one paternal uncle who died, and three paternal cousin brother. Out of three, one died, and one maternal cousin brother, and all of them are basically undiagnosed. This is the pedigree analysis of this patient family, and this is the patient, and this one paternal uncle was mentally and he died actually, and three paternal cousin brother and one maternal cousin brother. So based on the history, my summary is that there is a 39-year-old male with 10-year history of insidious onset, gradually progressive major cognitive decline, with the behavioral personality change in the form of apathy, loss of sympathy, empathy, agitation, disinhibition, disexecution with short-term or with and recent memory impairment. So basically, the structure involved are the dorsolateral prefrontal cortex, medial prefrontal, orbitofrontal, and medial temporal lobe. Based on the history, my differentials are the frontotemporal dementia, behavioral variant, frontal variant of Alzheimer's disease, or metabolic like hypothyroidism, or storage disease like Niemann-Pick's disease, or adult onset Tay-Sachs disease. With leukodystrophy, autoimmune or paraneoplastic cause, or any progressive multifocal leukoencephalopathy, basically HIV-related dementia. So on general examination, patient was alert, oriented, cooperative. There was general examination was normal with no pyelorectal cyanosis, clubbing, lymphadenopathy, or edema. There is mild graying of hair present with the mild temporal baldness. Otherwise, there is no cranium, facial, or spine deformity. Patient BMI was 24.6 kg per meter square. Patient was conscious, cooperative, but anxious on attention test in digit span. In the digit span for forward was 3 and for backward was it is 2. And days in week forward he was 7 out of 7 and in backward 2 out of 7 only. MMSE, the score was 24/30 and he was impaired in basically attention and calculation. He got 2 out of 5 and in recall 1 out of 3 and he was impaired in repetition. So basically the total score was 24 out of 30. Frontal assessment battery, the score was the 33 out of 18. He was not able to do similarities, lexical fluency, motor urea, conflict, and go and no go, but he was able to perform prehension behavior correctly. So he got 3 out of 18. Then side was intact, judgment was intact, proverb interpretation was impaired. Luria graphic sequence test was impaired, trail A and trail B was impaired. So this is a trail A and trail B test. This trail A test was he performed well. The trail A test, but he took more than normal time. He took around 100 seconds to complete trail A test. And trail B test, he is able to he was able to basically complete incorrectly basically. So he was not able to perform correctly the trail B test. This is a Luria graphic sequence. This is also mildly impaired. The shape and size is impaired. Even at last he was not able to perform it correctly. Primitive reflexes was absent, anti-saccades was impaired, applause sign was absent. Memory, the immediate reminder working memory was impaired, with recent memory was impaired, otherwise the remote cementing and visual was intact. Language was spontaneous speech was non-fluent, is prosodic, and it was very frequent with frequent word finding difficulty and impaired grammar. Verbal fluency was impaired with impaired repetition, otherwise the comprehension, naming, reading aloud, and reading comprehension, writing was intact. Either parietal lobe cortical sensation was normal. In the right parietal lobe, construction ability and geographical distribution was impaired with no impairment in the neck leg. So this was the patient construction ability. He was able to basically draw the diagram, but he was not able to done it correctly. This is a geographical distribution. Patient was asked to locate the Mumbai, Chennai, Kolkata, and Delhi on the map of India. He was not able to locate it correctly. Of all four. Left parietal, there was no evidence of any, there was no, on examination, there was no apraxia. There was no right to left disorientation, which was intact, no finger panosia, which was intact with impaired calculation. Occipital lobe was normal with normal field defect and cortical blindness. There was no cortical blindness. There was no Anton syndrome with intact visual nausea. And no canal vision abnormality, no prosopagnosia, and no evidence of any Balint syndrome. Cranial examination, the first cranial examination, second was normal. 3, 4, 6 showed the vertical gaze palsy with slow horizontal saccade and with broken pursuit. with the normal vestibular ocular reflexes. Otherwise, all the cranial nerves was normal. This is the video here. The patient is able to able to look at the right and the left normally, but he was not able to look up and down. Suggestive of vertical gaze palsy. This is the normal BOR. So this is suggested it is supranuclear vertical gaze palsy. So motor examination was unremarkable, with sensory also was unremarkable. With the abdominal, no cerebellar sign was there. There was no involuntary movement. Otherwise, other system was normal. There was no organomegaly and any other thing. So based on the examination, my summary is the patient is suffering from a major cognitive decline with behavioral and personality change, means the involvement of the DLP of median orbitofrontal with the median temporal. Non-fluent speech with fluent word finding difficulty and agrammatism, involvement of Broca's and its association area, and there was mild construction ability in geographical distribution, abnormality which involvement of the right parietal lobe, and there was vertical supranuclear gaze palsy with slow horizontal circuits and broken pursuit, involvement of the structure controlling the supranuclear control of the eye movement. So based on the examination, my differential are metabolic basically and the early onset PSP. I would rule out early onset PSP because there was no Parkinsonism feature and there was no history of the unprovoked fall. And there was the patient age is also 39, which is not appropriate for PSP. I would more go for metabolic diseases. On investigation, patient hemogram, LFT, RFT, ESR, FLP, TFT, ammonia, vitamin B12, iron profile, HbA1c, all were normal. Chest X-ray was normal. USG abdomen doesn't show any organomegaly. EEG was normal. This is the MRI of the patient, which is showing diffusely a loss of cerebral volume, which is more on the frontal and parietal region basically. FDC PET on FDC PET, there was moderate to severe hypometabolism involving bilateral frontal, parietal, and posterior cingulate gyrus percutaneous cortex with mild to moderate hypometabolism in the bilateral temporal region with sparing of basal ganglia and occipital cortex. On genetic test, patient found homozygotes for the NPC2 gene, basically Niemann-Pick2 gene, which is the autosomal recessive gene. This gene is found on chromosome number 18 and it is likely to be pathogenic in our case.
Thank you, Dr. Piyush, for a wonderful presentation. As you know, this is the middle-aged gentleman who has presented to us with 8 years history of progressive cognitive decline. So you must have observed that the MMSE in this was 24/30, so which is a borderline. So
yes,
here is a case who has a borderline cognitive decline, but when you look at the low function test, then you know he has more severe involvement. In day-to-day activity also, historically, he has a problem. So even if MMSE may be under a normal range or a lower range of the normal, doing a good quality of low function test will help you to determine what are the different lobes which are affected, and that will help you to decide whether the patient has dementia or not. Dr. Piyush, Dr. Kshitij will tell you more about this.
Yes.
Dr. Kshitij, please.
Good evening, everyone. I'll just share my screen. Good evening, everyone. I am Dr. Kshitij Bansal, Associate Consultant in Vedanta, Department of Neurology. So as Dr. Piyush described beautifully, our case who had dementia, which was young onset. So I'll talk briefly about the young onset dementias. So overall, all of dementias, about 5% of all dementias are young onset with estimated overall prevalence of 119 per 100,000 population. Between the age of 30 and 45 years, it is around 54 per 100,000 population, and between 45 to 60 years, it is around 98 per 100,000 population. And the incidence is around 11 per 100,000 population. So as you can see, the incidence and the prevalence of young onset dementia is still quite high, and it covers almost 5% of the dementias. So when to suspect, what are the red flags when we suspect dementia in a young? So individuals who have presented with new onset psychiatric symptoms without any previous psychiatric history, those who are middle-aged, had behavioral changes which are not consistent with the previous personality. There are progressive neurological symptoms or new onset seizures. There is any positive family history of young onset dementia, or minimal improvement of psychiatric symptoms following psychotherapy, counseling, or psychotropic medications. So how should we assess patients with young onset dementia? With a good clinical history, which includes symptom onset and types, especially ruling out frontotemporal dementia symptoms like loss of sympathy, empathy, apathy, and behavioral changes, physical health and other medical conditions, whether the patient is dependent on or for activities or daily living on family members or not, and about the drug and alcohol history. Next, very important is the family history. As we can see, the patient had an autosomal recessive kind of a family history. So we should obtain a detailed three-generational history of the in patients with young onset dementia. Then comes the physical examination, which includes detailed neurological examination along with lobe assessment, MMSE, Fab battery test, and all the horizontal and the vertical gazes as well. Then the risk assessment, psychiatric assessment, very important, with previous psychiatric history and symptoms and history of any learning disability and intellectual disability while the patient was in his childhood. And other neuroimaging in form of MRI brain and neuropsychological assessment is a screening test. So some of the important causes of young onset dementia are divided into the reversible processes and the irreversible processes. In the reversible process, as we know, very important, chronic SDH, along with meningitis and meningoencephalitis, with some of the intracranial SOLs, paraneoplastic syndromes, autoimmune encephalitis, Hashimoto's encephalopathy, and very important vasculitis, and some of the rares are the Whipple's disease, etc. And the irreversible processes, including DLB, Alzheimer's, young onset Alzheimer's, can still present with the memory impairment and lateral developing behavioral change. FTD, prion diseases, familial or variant, SSP and PMN. So as our patient had dementia along with other neurological and systemic features, so these are known as the dementia plus syndromes, which have cognitive impairment, which is accompanied by additional neurological and systemic features. So the patient with having young onset dementia with ataxia, so we should always think of some of the important differential, which includes spinocerebellar ataxia, especially 2, 12, and 17. In very important mitochondrial disorders, paraneoplastic diseases, fragile leg tremors, etc., tremor ataxia syndrome, and especially important is the Niemann-Pick disease type C, as there was in our patient. And patients having dementia with pyramidal signs, important differential are multiple sclerosis. As we know, in the long multiple sclerosis, patient can have dementia. Patients having FTD with motor neuron disease, hereditary spastic paraparesis, especially SPG4 variant, Alzheimer's disease with some of the pre-senile mutations, and vanishing white matter disease, etc. Patients having dementia with dystonia chorea, very important, Wilson's disease. Every patient of young onset dementia with a movement disorder, we should look for a Wilson's disease. Huntington disease, neurocanthocitosis, PCAN, NBIA, DRPLA, neuroferritinopathies, etc. And patients having dementia with buccolingual mutilations, differential diagnoses are quite narrow in form of neurocanthocitosis and very important Leigh-Han syndrome. And patients presenting with akinetic rigid syndrome, first very important is Parkinson's disease dementia, young onset Parkinson's, later on developing Parkinson's disease dementia, Wilson's disease, DLBD, and PCAN and BIA. And some of the dementias can have accompanied peripheral neuropathy in form of adrenoleukodystrophy, alcohol-related dementias, mitochondrial disorders, metachromatic leukodystrophies, neurocanthocitosis, and porphyria can also present with these symptoms. And now I will discuss some of the differentials patients having dementia plus syndromes along with the systemic features. So patients having dementia with cataract, so important differentials are mitochondrial disorders and myotonic dystrophy. One of the important is Wilson's disease, also presenting with the posterior subcapsular cataract. And patient having tendon xanthomas, one of the important differential is the cerebrotendinous xanthomatosis. Patient having splenomegaly can have Niemann-Pick disease type C, although our patient didn't have any organomegaly. And other differential is the Gaucher's disease. Patients presenting with dementia with anemia, very important, vitamin B12 deficiency should be ruled out in every dementia case, along with Wilson's disease, neurocanthocitosis, and Gaucher's disease rarely. Patients having dementia with renal impairment, important differentials are Fabry's disease, Lesch-Nyhan syndrome, and mitochondrial disorders. And with hepatic dysfunction, very important Wilson's disease and mitochondrial disorders. With respiratory failures, some of the patients with FTD, with motor neuron disease, can present with respiratory failure, and patients having NMDA receptor and limbic encephalitis. And with gastrointestinal dysfunction, celiac disease, along with the neurowipples and porphyria. And with our case, as our patient had vertical gaze paresis, which led to our diagnosis. So some of the important differentials, patients with young onset dementia with vertical gaze paresis is very important PSP, although the age is not fitting in our case. Others are Niemann-Pick disease, Gaucher's type 2 and type 3, and GM2 gangliosidosis. And some of the rarely reported, even in Wilson's disease, they have reported cases of vertical gaze paresis in Wilson's disease, along with PCAN and A-beta lipoproteinemia. Now I will talk briefly about our case, Niemann-Pick disease. It is a liposomal storage disorder which has acid sphingomyelinase deficiency. This is the ASM enzyme which breaks down the sphingomyelin to ceramide and phosphocholine. This sphingomyelin and this sphingomyelin and the precursor lipids starts to accumulate in the lysosomes, mainly the macrophages. And these lipid-laden macrophages then deposit in the liver, spleen, lungs, and brain. And the patient presents with hepatosplenomegaly, cytopenias, lung diseases, and the neurological symptoms. There are 4 subtypes, type A, B, and C, and E, but major are the 3 subtypes, in which the first type is type A, NPD, which is the infantile neurovisceral form, which has very low ASM activity, and it usually presents before the 3 years of age, and present patients have mainly hepatosplenomegaly and growth retardation. There are regression of developmental milestones, and all the patients have classic eye finding, which can lead to the diagnosis in form of cherry red spots, and the patient generally don't survive early after the past early childhood. Then comes the type B NPD, which is less severe than type A, has a missense mutation of SPMD1 gene. Patients present in the mid-childhood age has variable visceral symptoms, but minimal neurological symptoms. Mainly have hepatosplenomegaly, thrombocytopenias, and interstitial lung disease. Although 1/3 of the patient can have cherry red spots, which are also seen in type A NPD and other neurological symptoms. Then comes the Niemann-Pick disease type C, which occurs due to the mutation of NPC1 and NPC2 gene, which are located at chromosome 18 and 14 respectively. It usually affects adults, but there are reports where patients have early onset NPC as well, in which the patients have infantile jaundice, hepatosplenomegaly, or isolated splenomegaly. And 50% of the adult patient have without or minimal hepatosplenomegaly, which was seen in our case, has mainly neurological and psychiatric manifestation in form of vertical supranuclear gaze palsy, ataxia, dysarthria, dysphagia, and dystonia. Thank you, sir. I would like to ask respected Vinay Goyal, sir, to take this discussion forward. I'll just stop sharing my screen.
Thank you, Dr. Kshitij, for a wonderful dissection of the case and differential diagnosis and what should be the approach. For me, the learning point in this case is, first of all, this is a young onset dementia. Whenever you have young onset dementia, our first thing is to know is this a true dementia or a pseudo dementia. If I would see 100 cases of patients who come and tell me I have a memory loss, I think 80-90 patients, or rather more than that, will have a pseudo dementia. So doing an MMSE will give you a gross idea that patient has an dementia or not. But here the glaring point was this change in behavior for last 10 years. The activity by which he was socializing, he was reacting in the family and doing his business, all has changed in last 10 years. So that points me that this is not a normal case of dementia, or it's not a pseudo dementia, it's a true dementia. Second thing was, though he did not complain about his eye movement, but when we examined, his vertical eye movement was very grossly abnormal. And so in a patient who has a dementia and then had vertical gaze abnormality, then the differential diagnosis is very narrow, which Dr. Kshitij beautifully pointed out. So in this case, always the approach will be to do an first MRI brain. In our case, the MRI brain has shown that there is a generalized atrophy. There were no specific finding to point to any diagnosis. All routine investigation, blood and all other parameters was grossly normal. And so in such a case, it is always good to now we have a genetics which is available. And you have these disorders, when you have vertical abnormalities, so metabolic disorders becomes your common point of diagnosis. And when we did this genetic testing, his genetic test for pointing to Niemann-Pick type C disease. As we have learned from the presentation by Dr. Kshitij, Niemann-Pick is a spectrum of disorder which can appear from at birth to as late as late onset type of disorder. At birth, they may not have birth or infantile type. They may not have predominantly neurological disorder, but mainly developmental delay or hepatosplenomegaly is a major symptom in this child. When they have late onset disorder, then they may not have hepatosplenomegaly. If this patient would have had hepatosplenomegaly, that would have helped us to think of metabolic disorder more easily. But that was not the case here. So that was a little tough point to lead to this. Here, all other examination except behavior issues, which we have already pointed out, and cognitive affecting predominantly his frontal and so it was like a young onset FTD. If we don't have a genetic disorder, I will count this as a young onset FTD. The FTD can appear as early as at this age as well as later. Again, FTD has a big spectrum of disorder. As you know, there are 7-8 types of FTD being described, which could be associated with PSP, motor neuron disease, and spinal form, and a lot of other things, which is a point of discussion with the other case. Here in this case, somebody may ask me now what you will do. So after investigation and genetics, making diagnosis is easy, but unfortunately, treating this patient is very difficult because we do not have a definitive treatment right now. There are few drugs, including one drug is Meglutide, which has been studied very well. It decreases in early stage. If you start, it might help, but usually in India, when I was asking a lot of people, I did not find anybody who has used this drug and has an experience that what is the effect. From books, you would know that this drug is helpful, and there are more such molecules are already developed and approved by FDA. The best thing would be to have a genetic therapy, which is not in the pipe, not available right now, and there are a lot of trials are going on as far as genetic therapy is concerned. Are there any questions in the pipeline? Do we have some questions here? If there are questions, then we can answer them. Over to Shah Saab.
One comment which says excellent case, nicely discussed, is what is one of the, and no other question, but anyhow, my hearty congratulations for a wonderful discussion by the associate professor, Mr. Bansal, and the boy also presented very well. And I am sure that the postgraduates should remember the beautiful clues how to approach the young onset dementia, the various associations, and I'm very happy. I'm very thankful to you, Professor Vinay Goyal, for an excellent discussion. Is there any questions from anybody? Sir, Professor Sudhir Shah, sir?
It was an excellent disposition of the case and a wonderful discussion from several angles. And Dr. Kshitij has done a very nice cross section of the different aspects of dementia. I think it was a very good learning case. And as mentioned, dementia is not so simple. You have to check so many things, as he mentioned. You have to look from hair to eyes to mouth to liver, spleen, lung, everything, and everything might contribute to the diagnosis. That is one important tip. And as Dr. Vinay Goyal mentioned, MMSE, though, is a good, rough screening test, it may not be always so. So you have to be very careful in assessing or labeling something, whether it is dementia or not. We have to look carefully so many things. And therefore, it is better to check low functions or do Edinburgh cognitive enhancement test or so many other test batteries are available. So whenever you're in doubt. I'm recollecting one of the cases, like this, we have been also involved in a lot of dementia cases, but sometimes odd cases like young patient. I remember a patient who had obstructive sleep apnea for a long time, undiagnosed. He presented with profound dementia and was almost admitted with a semi-comatose state. And while evaluating the patient, we found out that he had a severe obstruction in the nasopharynx area. And after the surgical removal and the paletoplasty, the patient recovered completely. And he was suffering for so many years and moving from door to door for the diagnosis. So there are certain things which are very odd, and that also contributes to dementia. Routine things you don't miss generally, like B12, D3, TSH, PTH, calcium, etc. But these clinical signs and symptoms we have to listen carefully and evaluate. So I once again congratulate Dr. Vinay Goyal, professor, and team, Dr. Kshitij and Piyush, for this nice case, very good discussion, eloquent comments, and thank you. It was a really good learning. Dr. Lakshmi, I do agree with what you say.
I must say this is extremely rare case for students. They must know that this is not a common case you see.
Yeah, sure.
Extremely rare case, and one would, if you had to diagnose this case, it is very gratifying. Unfortunately, you can't offer the treatment, but at least you know when the in such a case, if the diagnosis is confirmed, at some point of time, you may have a new drug which might be able to help these patients.
Dr. Vinay, you will be surprised to know that our genetician has reported a case series of more than 100 cases of Niemann-Pick type C and PC.
Yes, sir.
In a cohort in Maharashtra and some part of Karnataka and nearby places where there are so many villages are affected, and he brought to my notice. So we had a chance of examining some of the adolescent and early adult population who had this. So sometimes, though it is rare, but it sometimes is found in certain communities also.
Yes,
That
sir.
I must bring to your notice. So there's
There
a
must be
paper they
some-
have already published.
must be some gene in a family. Here also,
Yeah.
family chart showed large number of people having the similar disorder.
Yeah.
Yes, sir.
Right now we are seeing a family near Talod where there are great number of cases of SCAR2. In one village, we have found about 24 people.
Oh my God.
So this is something we are going to visit the village within coming month or so.
Yes, sir.
Sometimes this cluster occurs in certain places.
Yes, sir.
Dr. Lakshmi, you must also have come across similar phenomena.
Yes, sir. Yes, sir. Yes, sir.
Sometimes we see such genetic cases like Niemann-Pick C or SCAR2 or 3 or 1 in clusters in one or two districts or villages.
Vinay, what is the drug of the recent drugs for the Niemann-Pick? Is it available in India?
Yeah,
No,
Maglitide is available. Maglitide we have been using in 2 patients, and we don't know the follow-up, but we recently started. It's very costly.
So it is around 30 lakh rupees per year. It's damn expensive.
The genetician whom I told, he has managed to get it through funded through some company.
Yes, sir.
So we are getting it free.
Okay.
Sir,
So
sir, actually, the rare diseases fund by the central government.
Yes.
In fact, we are getting it for the myozyme injections and all, no, sir. For the SMA, and in medical colleges, they buy and give, sir. It's about 1 crore per month. 1 crore per month.
Oh.
Enzyme
I'll ask you to approach the government for this. That's a good idea.
So now lot of funds is being given by the rare diseases consortia by the government of India.
There's some 500 crore kept separate for this.
If they want to do it, you can try it through that.
I will do that.
They purchase and give the drug, you have to administer.
Perfectly.
Try that. Please try that. Thank you. Thank you, sir. Thank you. There is no other questions. I think sir, shall I hand it over to the organizers, sir?
Please.
Thank you.
Thank you.
PhD.
Thank you, Dr. Kshitij
Thank you.
and Piyush,
Thank
for
you,
a
sir.
wonderful presentation.
So, sir, today it's a really great day. We are completing the 47th session of the Secret of Neurology. On behalf of Intas Pharmaceutical, I, Arun Chadha, Vice President, Intas Pharmaceutical, extend heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey over the past 47 months. And I would like to thank our Honorable Course Director, Dr. Sudhir Shah, sir, and Dr. Lakshmi Narasimhan, sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And we extend our sincere gratitude to Dr. Piyush, young neurologist, for their insightful case presentation. And we would also like to express our appreciation to Dr. Kshitij Bansal for their meticulous evaluation of the symptoms and investigations. And our special thanks to Professor Dr. Vinay Goyal, sir, the HOD of Department of Neurology in Medanta Medicity Hospital, Gurgaon, for gracious sharing their valuable experience and with this case and providing the crucial learning points and proceeding of this unique presentation. Sir has given all the summary and conclusion of this case. Once again, we are very thankful to all of you for your gracious presence. It's being clear in being with all of you today. In 48, we are coming up with the 48th session of Secret of Neurology. And we will meet in that 48th session on 28th June 2024. And most awaited next session of the Secret of Neurology, where we are completing our 4 years of the Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you very much, sir. Thank you very much. Thank you.
Thank you to Shah Saab and my friend Dr. Lakshmi for giving our team to present this case, and we really enjoyed
Thank you
this.
so much, Vinay. Thank you.
Thank you very much.
So much. Bye.
Thank you. Thank you
Thank
very
you.
much, sir.
Thank
Thank
you.
you.
Thank you.
Thank you. Thank you, sir. Thank you.
We must thank you because you accepted on the spot without taking a one second.
Sir, for me, it's an order from you.